Welcome everybody. This is the OCD North Carolina lecture series. We put these on, I won't say every month, but they're monthly as long as they last. So this current sort of series is January through April. And then we'll probably take a break through the summer and start up again in the fall. Yeah, just wanted to put in a quick plug for next month's lecture while you're all here. So we have Katie O'Dunn, who will be talking about faith and OCD. And I will put some more information in the chat when we get started, and you can check out some of the details of that talk and the full sort of schedule of events coming up. Yeah, hope to see you at some of those as well. Quick note about the talk tonight. So we will go for an hour. We do record the talks and they are eventually uploaded to our YouTube channel. So you can watch this talk, you can watch past talks. They're all up there. But just to note that we record the speaker and the slides. We won't be recording you guys, so don't worry about ending up on the internet forever. And we'll do Q&A at the end, but again, we'll stop recording before we do Q&A. So feel free to speak up, unmute. You can do all the things you want to do, again, without fear of living on the internet. I'll just remind you guys that we'll stop recording before we do that. All right. I am just going to introduce our speaker and then turn it over. We are very happy tonight to have Fran Kuehn. And Fran is a licensed clinical social worker with 25 years of experience providing therapeutic care to adolescents and adults. Fran is a diplomat in the Academy of Cognitive and Behavioral Therapy and has an earned doctorate from the University of Buffalo School of Social Work. Fran's research focuses on developing clinician self-efficacy with evidence-based practices that aid in closing the research to practice gap. He is an associate professor of practice at Simmons University School of Social Work, where he teaches advanced clinical practice courses in the graduate program. Fran also maintains a private therapy practice in Newton, Massachusetts, where he specializes in treating obsessive compulsive and related disorders using several modalities, including inference-based cognitive therapy, which we will talk about tonight. Fran, I will turn it over to you. I will clam up. If you need anything, give me a shout. I'll be here. And welcome. Thanks for being here.
Absolutely. And thank you, Ben. I appreciate the opportunity to have a chance to chat with you all tonight and talk a little bit about ICBT. And of course, there'll be room and time for some Q&A, or if you have questions, you can feel free to drop them in the chat. And then, Ben, I may ask you to kind of just track those questions if I'm going through slides and so on. It's not that I'm ignoring them, it's just that I'm trying to hit some points as we go through here. We'll try our best to get to all the questions you have. And I'll include my contact information here as well, so that if folks want to follow up or continue the conversation in any way, I'm happy to do that. And we've got a really nice group of people here, which is really fabulous. And Ben, you'd mentioned that there's some interest in this as a subject, which I'm really glad about. Of course, when it comes to things like implementation science, it's a wordy term about like how do we get good practices in the hands of people who know how to use them, or how do we really help increase people's awareness about things? And ICBT is one of those treatments that I think is really kind of starting to turn the corner in terms of people knowing about it, hearing about it, wanting to know more. And I'm really thrilled to be able to share some more details about this approach, because it's something that I really think has some great legs behind it. And as I hope I'll be able to communicate to you tonight, that it offers, I think, a really valid alternative and a powerful alternative to the current practices that are out there that are also fabulous. And that the really exciting news about the emergence of ICBT is that we have options, and that where for dealing with conditions like OCD that are so debilitating and so difficult, where we have one treatment that works well but not perfectly. It's always important to think about, well, what else could we do? And I think ICBT gives us one of those options. What else can we do when something like ERP, for example, just isn't getting the kind of traction that we hope to, whether it's people who are here who might be sufferers or clinicians treating the condition of OCD. So with that in mind, I'll talk to you a little bit about how we would make distinctions between what ICBT is versus the way that ERP looks at the condition of OCD, and try to then create some gaps between those two approaches conceptually, because they really are very different. And then do a little bit of a deeper dive into how ICBT works, actually. And I'll try to sprinkle in some clinical examples, and then if you have questions, again, drop them in the chat or let Ben know, and we'll try to get to them at the end if that works for everybody. How's that sound? Like good use of our time? All right, let's do it. So I'm going to switch to this, and then I'm going to do that. So, so here's what we're going to cover for tonight is inference-based cognitive therapy for OCD. And here we are with the Bowl City outfit here, which I'm excited to be a part of. So first of all, I don't have any disclosures to talk about. There is a nominal speaker fee for these events, but the books and things that I talk about here, I don't have a financial interest in promoting. I don't have an outside of my own practice, have a financial interest in talking about ICBT in any way. I'm really just excited to share this information with you all. But if you are interested in learning about ICBT, the original clinician's manual is available online and other places, published by Wiley here, and this is the title page. So, Clinician's Manual for Obsessive Compulsive Disorder by Kieran O'Connor and Fred Ardema, which you can check out at any point. It's a little dense. There have been some updated materials that are out there that make this a little easier to understand, and I hope that this lecture will help promote that as well. But one of the first questions we get is, well, what's the evidence behind this? I've never heard of it before. And like most therapeutic interventions, the intervention itself is tested in trials of different kinds, but also the elements of the intervention, like the building blocks of it, have been assessed as well. And that's true for ICBT too. So the earliest research on ICBT, or the components that make up the ICBT approach, happened in the 1990s, and have been ongoing ever since, including some randomized control trials that were published this fall, actually. So we are well, there's not nearly the amount of research on ICBT as ERP, and that's a fair statement. But the research base is growing. And you really have to think of it as a body of evidence. It's not just the approach itself, but the components that make it up. There's over, at this point, 90 peer-reviewed publications about all these pieces of ICBT. There have been 5 published controlled trials or randomized controlled trials, which are considered almost at the top of the evidence hierarchy in research. 4 were randomized trials with ERP as a control group, and I won't get too into the research nitty-gritty here, but high quality research done on this as an intervention, where the findings were that the impact of ICBT was no worse than ERP. It worked about as well, and in some cases a little bit better, because it was a little bit more tolerable than having to do exposure work. And we'll talk about that a little bit too. It turns out to get benefit from therapy, you have to be willing to stay in it. So if the approach feels a little more tolerable to some people, then we're going to probably help them out a little bit more. And for individuals who are very fused with their OCD, who have a hard time kind of seeing a difference between what is real and what is their OCD, that this ICBT approach was actually designed to address that through what we'll come to know as inferential confusion. And that's what the I stands for in the ICBT. And then there's a meta-analysis of all the studies that I think hasn't quite hit the shelves yet here in 2026, but had been worked on up until this point. So we have more research coming to look forward to. And as I said a moment ago, the best news about this is that it means we have options in the treatment of one of the more disabling conditions worldwide. But if you're a clinician and or a client or patient who's gone through a course of ERP, this can feel a little weird. And so I invite you to kind of bear with me here, try to think it through. It will require a bit of um, a paradigm shift in the way that we think about what OCD is. And then it'll start to be clear why this approach would look at things differently, because it really is a different conceptualization of what OCD is at a fundamental level. And so I was trained in ERP. I did the Behavioral Therapy Training Institute a number of years ago, and which is our gold standard for training in ERP, and was very much infused in that approach for a long time. And when you do ERP, you really learn that OCD is a bunch of obsessions that seem to kind of come out of nowhere, the thoughts, urges, or images that come to mind that are so distressing and create this negative impact that we feel like we have to do something about it. And that's the doing, that's the compulsion, right? I have to now check because I have thoughts about what if I left the stove on, or I have to ruminate because I have thoughts about whether or not I said or did the wrong thing with my friends this weekend, or I have to do some other thing to try to manage these obsessions that we have. And that the typical pattern, the way we think about it with ERP, is that you have these intrusive experiences that create these negative feelings and an urge to do something about it, to get some relief. And even if you get some relief, you're right back where you started and wind up with the same or different intrusive experiences. And the pattern goes round and round and round. And so the idea is, how do you stop the pattern, right? In ERP, you stop the compulsive behavior. You say, I'm just not going to do the thing that keeps the wheel turning here, and kind of learn to live with the consequences of that. So we think of these intrusive thoughts as unwanted, random, they kind of happen to everybody, but somehow people with OCD can't let go of them, while folks without OCD have the same thoughts or worries, but somehow can let them go. And so, again, the treatment becomes, well, don't get so involved in those thoughts. Don't engage in compulsions to try to rid yourself of them. Don't fight them off. Act in ways that actually align with your values here in the world, and that works, right? It can really help. The goal is to try to stop it, right? And get used to feeling uncertain, get used to even feeling fear so that you can habituate to it, or maybe tolerate uncertainty. It could be true that I left the stove on or not, or said the wrong thing or not, but I can't figure it out for sure. So let me learn how to live with not knowing. And to step away from those thoughts as experiences that are negative and pull me away actually from things I'd rather be doing. So why not go and do the things that make life meaningful for me instead? Really, really beautiful therapy when you think about it. And so we want to break it down a little bit because you've got treatment targets here, and to make a distinction, what ERP is doing is targeting, the negative feelings and the compulsions that show up in response to these intrusive experiences, these triggers. And so we'll make some contrasts here with the three typical interventions that we might use for OCD. So ERP's treatment target is to stop the compulsions, learn to live with the bad feelings. And I'll return to this slide. I know there's a bunch on there, but hopefully it makes sense. But one of the troubles, though, with ERP is that it treats a lot of our OCD experiences like it's a phobia. And what does that mean? Well, phobias occur when we're in the presence of something that causes fear. If I have a fear of heights, I generally don't feel afraid of anything until I'm up in a high place. And the thing about OCD is that the fear happens even when there's nothing going on to justify it. It's more of an internal experience. But what ERP says, similar to what phobias are, is that you've got to expose yourself to this thing and kind of get used to it, like drive over the bridge, Fran, 100 times. So you get used to feeling afraid, and then you don't feel that fear anymore. You've habituated to it. And so exposure is based on that principle, and it works actually extremely well for phobias. And that the content doesn't matter. So whatever you worry about isn't, we don't have to get into it at all. And that if you just habituate or learn that you're safe here with repeated exposures, that's what's going to make a difference in your treatment. And learning how to tolerate uncertainty is the goal. Will the bridge collapse under the weight of my vehicle or not? I don't know. Maybe yes, maybe no, but I'm going over it anyway because it matters to me to get to the other side of the bridge. And I have this motivation to live my life according to these values. And as I continue to do that, I learn that the thing that I'm afraid of isn't actually happening. And so I inhibit the fear response the next time I get out there because I'm learning new information that overrides this, worry that the bridge could collapse or I could lose control or something like that. And ERP really works for about 60% of those who try it. And we have a real problem with access to high quality ERP or OCD treatment generally, which outfits like Bull City are just amazing because they're easing access in a lot of ways to people who suffer with this condition. Um, but the outcomes for ERP tend to do a little worse for people who are really fused with their OCD. And there's high dropout rates in every kind of therapy and not too much higher in ERP than for anything else. But like most therapies, people drop out if they don't feel like they're getting much out of it or they're too scared to do it. So we really have to think about how do we offer treatments that people can engage in. And another hidden, kind of problem with ERP is that a lot of therapists feel kind of weird about doing it. And they worry about causing harm and they're kind of reluctant. So finding therapists like Ben and his team is such a godsend because you've got people who really are well trained. But finding a typical therapist in the community who knows how to do ERP, as I'm sure as many of you know, is really hard to do. You really have to find a specialist. And these feared stimuli, they tend to kind of come up and you do exposure to one thing and then that kind of goes away and that's good. But maybe a week or a month or a year later, something else comes up and now you've got to do ERP to that. And it can feel a little bit like you're playing whack-a-mole. And it requires an intense anxiety experience. In the world of ERP therapy, we think about expectancy violation, which technical term for I thought it would be like this, but it was actually like that. And the bigger difference that you can create between that, I thought it would be terrible and terrifying, but I actually learned how to live with it. The bigger difference you can make, the more gain you get in therapy. But you've got to create a lot of high anxiety provoking situations to get there. And that can be hard for people. Folks sometimes aren't really willing to do that. And then there's some themes that have to do with shame, taboo themes in particular, that it's difficult in my experience personally to ask clients to learn how to tolerate. Um, and to where one of the first times I had a little bit of a departure from ERP conceptually was working with people who worried that they could harm children and that they knew at some level that they wouldn't or didn't want to, but they could not shake the persistent fear that they could. And saying, well, maybe you could, maybe you couldn't, to me didn't really seem like the right place to leave it. So I see the value in it generally, but there's some taboo themes where I think actually we could probably do a little better. So, in contrast to ERP, this is a little academic, so sorry, but the classic CBT target is about consequences and appraisals. What's the evidence for the idea that I could get sick and die if I touch this thing? And I think what we all know is that when we go down that rabbit hole, we wind up just kind of arguing with the ER with the OCD. Well, maybe I'll get sick, maybe I won't. I guess I won't, but what if I do, right? And then you just wind up spinning your wheels and feeling more frustrated. So we learned pretty early on that classic appraisal-based CBT actually can worsen OCD and that we don't really want to do that at all. So we've got ERP, which works, well and to some extent, classic CBT, which we're really not doing and shouldn't be doing, and then ICBT. So again, classic CBT here is let's look at the evidence, let's look at the appraisal here, and you've got these kids on a roller coaster, and you can see they're all in the same situation. They're all in the same boat, but they're looking at the situation very differently. If you take a look at the kid in the dark shirt versus the kid in the light shirt, two very different reactions to the same situation. So Becky and CBT will say, hey, you should really have a more accurate appraisal of what's going on to not feel distressed. Once again, the second you do that with OCD, you wind up arguing with it, going down the rabbit hole, finding doubts and worries about it, and undermining your own thinking in ways that kind of keep you stuck. So we're not going to do that. In ICBT, we're going to do something really different. And we're going to work all the way at the front of this sequence. And so what's a sequence? Well, there's a trigger, right? And then in ICBT, it's what we call an obsessional doubt. Not an intrusive thought, not a random event, but a specific doubt about something that's possible and that has consequences. But as we're going to come to see, may or may not have relevance to the here and now. And I'll explain that as we go. But in this sequence, we really think of all OCD as following this pattern. So a trigger, an obsessive doubt about it, then a quick move to how bad that could be, the consequences of what that could mean, what I call the bucket of bad feelings. I could feel, of course, anxiety, fear, shame, also disgust, guilt, just tons of bad feelings, and then compulsions that kind of show up to try to rid ourselves of that. So in ICBT, we're looking more at the obsessional doubts than we are at the compulsions. So instead of saying, if you have this worry that you touched a doorknob and now you could be contaminated by something, that in ERP, we're going to say, well, touch the doorknob and don't wash your hands. So like it's all about the response prevention. And then learn to tolerate the anxiety. You'll habituate to it or accept the uncertainty that there could be germs on your hands. And what ICBT says is we can work earlier in this sequence before we're dealing with the compulsions and start to look at what are the doubts. How do we come to the conclusion that maybe we're contaminated, or maybe the door is unlocked, or that you could go crazy, or that mole on your skin, or the ache in your hip is cancer, or something like that. And in the next few slides, I'll kind of take you through how we look at these doubts, where they come from, what they mean, how they get generated within people, and how it starts to explain their OCD in a way that I think kind of honors their lived experience and gives value to the narrative that goes through their mind about what could go wrong. So we're not saying it's random. We're not saying it comes out of nowhere, and we're not saying that they have trouble with these intrusive experiences that other people don't. We're actually shifting that paradigm and saying, actually, these are doubts about things, and that those doubts are a function of inferential confusion. And we'll talk about that. Okay, so first and foremost, a distinction we want to make is that OCD is not a phobia. If I get afraid of driving over bridges, that's only when I'm driving over bridges do I really get afraid of it. So my fear occurs in response to the presence of the thing. And that again, if I just keep it up, keep driving over the bridge, keep hanging out with spiders, keep petting snakes, doing all these things, I'm eventually going to get used to it for all those reasons, the habituation, the extinction learning, inhibitory learning, that's all really going to help. but OCD isn't a phobia. Because here's an insight here. When we really think about what is OCD, that 100% of it occurs in the imagination. OCD is never really about the things that are in front of us, even if it's a stove or a door handle or a faucet. One of my clients stares at the faucet, um, worrying that there could be something wrong with it and that it's broken, and that when they actually shut it off, they broke some mechanism within it, and that what could happen next is a catastrophe, a flood, terrible damage, um, ruining their reputation, becoming someone who is irresponsible or neglectful in such a way that they would cause a disaster. But none of those things are actually happening in the here and now. When you really think about it, 100% of OCD occurs in the imagination, not in response to things that are in the here and now, although those can be triggers. So they occur in response to an imagined scenario, a story, really, about what's possible and what feels real. But as we're going to come to see, we can tell a difference between that and reality. So we ask these questions a little bit, starting to get at this inferential confusion, because if we're going to worry about something, we should be thinking about, well, why is it justified? Or really, what would have to be happening to justify the worry? Well, I would have had to do something to that faucet handle in such a way that created a broken mechanism in such a way that started with a small drip and then led to a gushing um, fountain of water in this bathroom that would soak everything and ruin the floors, and then it would cause so much damage that everybody would be so upset with me for ruining this thing, right? Like all those things would have to be happening to justify the worry. Or another way of asking the question is, what would you have to be certain of in order to not keep staring at the faucet, right? What would you have to know for sure to be able to walk away? And these questions open the door to those obsessional doubts about things. So, in this way, we're not really targeting the compulsive behavior, nor are we arguing with the content um, of the whether or not how likely it is, what's the evidence for and against the idea that I've broken the faucet. We're looking at the nature of the doubts. So ERP, again, very powerful therapy here, is a behavior therapy. So we change what we do in order to change what we know. We stop washing our hands so we can learn something about tolerating uncertainty, or learn that we can tolerate that anxiety, or that we can habituate to it. So, but it requires us to give some credence to the initial doubt that came as a result of the trigger. So it's like working within the bubble of the OCD, uh, allowing the story of the OCD to be prominent while we then stop the compulsive behavior that um, is designed to make that story not come true. So, in contrast, ICBT is a cognitive therapy. So, we change what we know or focus on what we know. And in the knowing, it allows us to change what we do. So, behavior versus cognitive, and that's the ICBT distinction. So that's what we do. We target the obsessional doubts, how they get constructed, and how they come about, and why they are particular to us. And why is it I have doubts about this faucet and somebody else has doubts about hurting children? And somebody else has doubts about running someone over with their car, and somebody else has doubts about whether or not they said something offensive, right? That those doubts are actually really personal, and that we want to honor and validate that story, that it means something to that person for a reason. And they've come about this honestly. It's not random, it's not out of nowhere. It's something that's personally a vulnerability to them, something that they really worry about could be possible, that is particular to them. and what they care about in the world. So how do we think about this? Um, OCD is a problem of reasoning. That's why it's a cognitive approach. If we can reason our way into OCD, we might have a shot at reasoning our way out of it. That all of the reasoning in OCD follows a very predictable pattern, and this is applied to every OCD theme. So while it can be helpful to think about, well, I have relationship-based OCD, or I have pedophilia-based OCD, or I have harm-based OCD, ICBT makes no distinction between any of those themes and just allows us to see the pattern as it is. It's universal. And that this reasoning, however, is a powerful method by which we use to solve everyday problems in life, but somehow are applying it to our OCD in such a way that makes the experience of OCD feel so real. Right? How many times have you said it or heard from others, like, I know it's not, I know it's crazy for me to think this way, but it feels so real. And we're going to talk about why that is. So, yes, there is a possibility here, and I believe it, that if we can reason our way into OCD, we can reason our way out. And here's the pattern, as I showed you in that treatment slide a little while ago. All OCD follows this pattern. We have some information about something. I'm looking at the faucet, and then something happens, right? That there's, I can call this sort of a trigger, faucets, potholes, children's playgrounds, whatever it is, nieces coming over for a visit, washing my hands after I prepare a meal, right? Any of those things that I have some information, but there's something about that information that isn't trusted, or things I start to doubt. And that becomes obsessional uh, doubt, and as we're going to see, precisely because there isn't any evidence that supports it in the here and now. It's something that's obsessional because it's only coming from the imagination. And here's where the imagination takes over. So once we're in the imagination, anything is possible. Consequences start to cascade and come really fast. And it's almost automatic, where we enter the imagination about what could go wrong and wind up really, really stuck. Thinking about how terrible those consequences would be. We couldn't live with ourselves. Our lives would be ruined. We'd become the kind of person we really don't want to. And then we just feel terrible, guilt, shame, disgust, and sure, anxiety as well. And then these compulsions show up as a way to rid ourselves of the bad feelings, but really to try to resolve this obsessional doubt. If I could just stare at this faucet long enough, I'd be able to convince myself that I didn't have to worry that it could break and all the consequences that could happen. But as we all know, these compulsions actually don't solve the problem. They tend to make it worse. But all OCD follows this pattern, no matter what theme you might be experiencing. And so, how do we make a distinction? What's an obsessional doubt anyway? Well, they're not a compulsion or an obsession. They're not a random intrusive thoughts. They're a doubt about something. And it's a part of a thinking pattern. It's like I have information, but then I doubt it. And that the person with OCD doubts the information that's available. I could see that the faucet is off, but I'm doubting something about it. And what's happening is I'm going into my mind and I'm thinking, well, what if it's really broken? And that would be bad because, and then that would be bad because, and so I better stare at this thing to make sure none of that happens, right? That these are remote possibilities. And the key word is possibility. And the fact that they are possible seems to add legitimacy to the OCD doubts themselves. So, in addition to things being possible, there are out of context facts that get brought in. Things like, well, sometimes faucets break, or I've been around faucets before and I actually broke one time, Or I heard about somebody who broke a faucet, didn't know it, and it flooded their whole house and ruined everything. Or in order to be a responsible person, you're supposed to make sure that faucets are off. So all of these things are true in the abstract, but since none of them are happening now, they're actually out of context. But at the same time, they seem to justify the worry and doubt that people have. So the same thing, this is going, at the same time this is going on, I'm thinking in my mind about what could be possible, how bad that would be. At the same time, I'm losing a sense of connection to my senses. And that includes what I can see, hear, smell, taste, touch, but also a sense of who I am as a person, what my intentions are, what my desires are. We lose all that because we're infused in the doubts and then the consequences that feels so real. And this is the heart of inferential confusion, prioritizing remote possibilities over here and now sense data, right? Dissolving our senses away and going into the imagination and thinking about all the things that could go wrong. But uncertainty is something a sort of more typical situation where we simply don't have enough information about something. And uncertainty we can resolve. If I don't know what the weather's going to be, I'm uncertain, and I have to look at my app and tell me, should I wear a coat today or not? If I don't know what my test results are, I'm uncertain, and I've got to wait and get a call from the doctor or get my exam back from the professor. We just don't have information until we do. So what if it'll rain today? And yes, it is hard to tolerate uncertainty. Getting a medical exam and having a test result that you're waiting for is hard for us all. So learning how to tolerate uncertainty is helpful in these cases, but ultimately we get information at the end that resolves this. You get the call back, you didn't get the job. Too bad. We'll learn to live with it. So we can use these things to go from uncertainty to certainty. And if we can make that move, then we're not dealing with OCD, we're just dealing with life, unfortunately. Life isn't totally certain all the time. But back to these inferential confusion, right? That these are conclusions about things. Again, prioritization of remote possibilities over our senses here and now, justification through the use of logic applied out of context, and distrust of our senses. It's these three components that make up this concept. And inferential confusion has been tested in these randomized trials I've talked about and found to be independently linked to the severity of one's OCD. The more inferential confusion people have, the worse their OCD symptoms are. So, how does all this work? Well, OCD takes advantage of these obsessional doubts by creating narratives and stories about what's possible, and that these narratives and stories are part of what makes things feel so real, right? So, learning how our mind works and how we leave the land of our senses behind and go into our imagination is part of the education, psychoeducation, and therapy of ICBT. And here's a key distinction. People with OCD reason very effectively in many other parts of their life, except for where the OCD shows up. I use this example all the time with folks. Imagine you're crossing the street. You press the little button on the crosswalk, you wait to hear the chirping sound, and you see the white figure, and you're not doubting that you're going to get run over by a semi if you cross the road, especially if you don't see one coming. But people with OCD worry about imagined possibilities all the time, except for, when they're crossing the street or answering the phone or doing their job or doing everything in life except for where the OCD shows up. So what's going on? How is it that they're reasoning one way in regular life, but then with their OCD, they're reasoning in an entirely different way? So here's an example. Now, I could be in a relationship with somebody, right? And then there's an obsessional doubt. What if I'm not attracted enough to my partner? And that this is supported by logic. People end relationships all the time. Now I'm thinking about it. I saw that movie last week about the breakup. My friends just broke up. I've had breakups. And if I was in the wrong relationship, it would be awful. I'd be lying to myself. I'd be inauthentic. I'd be someone who was leading someone on. That would be terrible. I would be a horrible person who doesn't deserve love. So all these things combined together into a whole story about who you could be, about how awful you could be, if this doubt is true, and that the obsessional doubts create all this as a narrative, and that the compulsions, checking, asking for reassurance, talking to my partner, checking for my groinal response, am I really attracted to men or women or what, is designed to try to make sure this story never comes true. So as we're going through here, think of a case yourself about a narrative that could be explaining why someone would be worried about something. What does it say about their worries about themselves? And how does this come together? Doubts, logic, storytelling, and the fear itself. Well, if we take this through in a sequence here, we're going to look at the doubts occur on a surface level. I'm driving along, I hit a bump. That's a trigger. Then I have an obsessional doubt. What if that bump was a person? Um, and again, obsessional doubts occur without any real evidence in the here and now. They're only occurring in the imagination. But even though it's only occurring in the imagination, it starts to feel real because it's supported by things like facts, rules, hearsay, personal experience, and endless possibility. So, facts are sometimes people get run over. Rules, you're supposed to be careful on the road. Hearsay, I've heard about people being neglectful in their cars, looking at their phones and running people down. I myself have been distracted in the car before, and so anything is possible, even though I think it's kind of crazy that I'm driving around in circles for an hour. It's possible, and I have to make sure that never comes true. So the logic deepens the story, creates a narrative filled with vivid imagination, imagery, ideas, worries, and that folks with OCD tend to be pretty creative, intelligent, and empathic. And I think personally that these three elements really make people vulnerable to OCD. And one of my heroes in the ICBT world says, OCD is like being the main character in a disaster film. You're trying like hell to prevent this bad thing from happening. Um, and that this narrative leads to what we call the fear itself. What if I ran that person over? I could be the kind of person who is neglectful, capable of harm, inauthentic, someone who could go crazy, right? So we think about it this way. If you go to the movie theater and you go to one of those multiplexes and you go into one theater and you think you're going to go see that rom-com, but it turns out you walked into the horror film. That entire movie experience is designed to make you feel a certain way. The music, the lighting, the sound, the sound effects, the forebodingness of it all is going to create an atmosphere that feels real. And what we're trying to do in ICBT is help people recognize that you're in the movie theater and we can get out and enter the light of day again. So living with OCD is sort of like trusting our doubt, trusting the doubt and doubting our reality, right? And what we're trying to do is trust our reality and doubt the doubt. So ICBT holds out the possibility of restoring trust in your perception and your memory and yourself. So this is about restoring trust in those senses, and I think it's a very validating treatment in that way of you can trust your eyes when it comes to the faucet, just like you can when you're crossing the road. You can trust your sense of self when it comes to taking care of your niece, just like you can trust yourself when you're, taking care of a patient, right? It's you can trust and return trust in these things. This is a long quote from a Stephen King novel. The beginning, I think it's the foreword to Night Shift, and I'll give you a second to read it. And this is the difference between obsession and narrative. So here's where it goes. None of them are real. The thing under my bed isn't real. I know it's not real, but I also know that if I keep my foot under the covers, it won't grab my ankle, right? That the narrative will pull us in ways that's really compelling. And so this feared self is thought to be at the heart of people's OCD, that we could become someone we desperately don't want to be, a monster or someone who's negligent or crazy. But it's the opposite of who we really are, and that the compulsions show up to try to prevent this feared self from coming true. I drive around the block over and over again because I can't stand the idea that I could be someone so neglectful as to miss the fact that I ran someone over, right? Or with the faucet, or the contamination, or the relationship, or the child. So this narrative logic and feared self work together to keep people in the bubble of their OCD, keep them separate from their reality and being able to sense reality, and stuck doing compulsions, trying to solve problems in ways that don't work. And that inferential confusion is the heart of that process. Because we get convinced that if we just keep going, we're living in the bubble, we keep trying to figure it out, um, that we're somehow going to find that certainty, that we're not our feared selves. And all we really need to do is restore a sense of trust in who we are. There was a time before the OCD, and then that was when we trusted ourselves. And then the OCD showed up and took that away from us, and we want to get it back. So we don't want to go further into the bubble. We want to restore a sense of trust in our senses and who we are, because being in the bubble makes us less safe. Actually, it's an ironic process with OCD. I worry tremendously about, what if I said or did the wrong thing among a group of friends? And because I'm so focused on that, I'm not present to my friends. They see me as distant. Maybe not, they think I'm not having a good time, and they don't call me up for the next time they hang out. I've actually made myself less safe because of OCD. So this imaginal absorption into the senses, getting pulled into a daydream, or what's called dissociative absorption. The worse this is, the worse people's OCD is. And our job is return a sense of trust to our senses. Um, and so the goals, what do? We understand the sequence that all OCD follows the same pattern. We talk about the role of narrative and logic and possibility and how it crafts this whole story in our mind about what's possible, but ultimately isn't occurring because there's no evidence, that there's nothing in the here and now that justifies it. That the experience of OCD is about prioritizing imagined possibility over reality in the here and now for good reason, and that people with OCD, we want to validate that and say, you've come to this honestly, you're not crazy. Of course, you're worried about it. You're just applying this reasoning in a confused way, and we can help you restore a sense of trust in yourself. We acknowledge that they doubt certain parts of life, but not others. Why the hell is that? Well, it has to do with who they worry they could become. And they're working really hard to make sure it never happens. And that's why they get pulled in. So we practice restoring a sense of trust in the senses, understanding the role of the imagination, and how our feared selves are vulnerabilities within ourselves that the OCD takes advantage of, pulling us away from what we could know about ourselves and making us worry about what's possible. So we learn to trust our senses effortlessly in all of life, not just where the OCD doesn't show up, but where the OCD is. And once we've restored a sense of trust in those senses, we can often really diminish the role that OCD plays in our lives. That you can see yourself as who you really are, not someone who is, this twisted version of yourself that is possible. But again, um, there's no evidence to suggest that's actually who you are. There's nothing happening in the here and now to justify it. So very quickly here, treatment scope and sequence, as always, an assessment period. There are some questionnaires that we could use here that will help with this. The ICBT method is broken into these modules. They don't have to just be done in 12 sessions, but often figure, 10 to 25 sessions or so before you get some good results. And that for clinicians here, best advice I could offer is go slowly, help people come to their own realizations about how their OCD has shown up. And that it's a very cognitive, psychoeducational learning type approach with a lot of homework and practice in between that helps people restore a sense of trust in themselves once again. So I'll pause there, knowing we probably have a couple of questions, but wanted to take you through some of that, and I hope it made good sense to you.